Well, we're going to kick off the new year with another biomechanics lecture. And this is one that I think many of you will find intriguing because it's a topic that's actually not taught in the podiatric medical schools and actually rarely taught at any seminars. Interestingly, being taught quite a bit now in surgical symposiums. So sit back and relax and let's talk about the twisted plate. This all really started for me about 20 years ago and became the backbone of my book, which really was an effort to go back and figure out why all these foot problems occur and understand them better before we actually try to treat them. And much of what I'm going to share with you tonight is in this book, which you can purchase online at springer.com. And you can order chapter by chapter. And the opening chapter and the second chapter are devoted to the ontogeny, the evolution of the human foot, and the twisted plate. I think it's important that we study the pathomechanics of foot and ankle disorders. And in my book, I felt that it was important to look at the evolution and specialization of the human foot. More importantly, to study what features of the foot are unique and really allowed the human to assume an upright bipedal ambulation. And interestingly, those unique features actually are those that are most vulnerable to failure. The lateral ankle sprain with anterior talofibular ligament rupture, plantar fasciitis, first ray deformities with hallux valgus, hallux rigidus are really all unique injuries and conditions to an anatomic structures that are not found in other primate feet. And then we want to kind of develop strategies to restore function when these structures fail. And at the end of this lecture, we're going to talk about direct clinical applications. This is a great quote from Frederick Wood Jones about the human foot, specifically comparing the comparative anatomy. And he says it's a human specialization, and whether he be proud of it or not, it is his hallmark. As long as man has been man, and as long as he remains man, it is by his feet that he will be known from all other members of the animal kingdom. That the foot is clearly a differentiating feature of humans compared to other primates. This became really clear to me in the chapter on adult acquired flat foot, because as we studied the three-dimensional breakdown of the foot, it began to resemble the primate foot, the non-human primate with the midfoot break and the severe valgus rotation of the rear foot and the forefoot. Most notably, the movement of the talus away from the calcaneus, where they almost begin to lie side by side, which is exactly the anatomy we see in most other non-human primate feet. The twisted plate is a description initially of the osseous configuration of the human foot, which is unique, and that is the vertical orientation of the talus and calcaneus, and then the reciprocal horizontal orientation of the metatarsals. This unique configuration is not seen in any other primate species, and it's this configuration that enables the remarkable mechanics of the human foot for upright ambulation, for walking and running. So this perception of it as behaving from an engineering principle like a twisted plate was really coined by a group of anatomists, and I'm going to go through the history of this in a moment. And they really looked at the comparative anatomy of other species to learn how the human foot evolved to provide bipedal locomotion. And in so doing, they really identified these unique changes in the osseous structure, as well as the formation of new ligaments in the human foot that are not seen in other primates. They proposed a mechanism of how the arch mechanism of the human foot is established, and also how the windlass mechanism is engaged for optimal foot function. The first anatomist who really coined the term the twisted plate was Michael McConnell. And McConnell was an Irish anatomist who published this landmark article in the the proceedings of the Royal Irish Academy. And this was back in 1944. And basically, in this landmark article, he described the appearance of the human foot compared to the hand of a human. And compared to the hand, he described that the human foot and the bones of the foot are arranged in a torsion or a twisted appearance. And he coined this term lamina pedis to describe how the bones of the foot are arranged in a plate-like arrangement. And very interestingly, he excluded the talus from the lamina pedis, and we'll talk about that more later. He described how pronation of the forefoot twists the foot plate and creates the arch arrangement of the foot, and how supination untwists the foot plate, and he observed how it tensioned certain plantar ligaments. To quote from the opening of the paper, he says the bones and ligaments of the human foot form a twisted osteofibrous plate of irregular thickness. The degree of torsion of the tarso-metatarsal part of this plate is alterable. Importantly, he points out that the torsion of the foot skeleton is actually brought about in intrauterine life. We'll get back to that in a minute. O.J. Lewis followed McConnell in the 70s and 80s, and rather than comparing the foot plate of humans to the hand of humans, he compared it to other primates and wrote a number of very important papers that are listed here. A key quote from one of the papers is the fact that a key event in really comparing all other feet to the human foot is what he calls the superimposition of the talus upon the calcaneus, the stacking of the talus on top of the calcaneus rather than next to it. This introduced a new flexibility in the foot, providing inversion and eversion of the subtalar joint complex. And he also pointed out that the human foot evolved to the point that the fibula no longer has any contact with the calcaneus. I'm in New York City now, and a week ago I visited the Natural History Museum and saw, really for the first time for me, to actually see a skeletal model, this time of a chimpanzee's foot. Actually, I'm sorry. Yeah, I believe it was a chimpanzee, maybe a gorilla, because I really wanted to see how the fibula did actually articulate with the calcaneus. Very easy to see, particularly in this right-hand image, and how adducted the talus is from the calcaneus. And the fact that the talus and the calcaneus really lie almost themselves flat on the floor. They're certainly not stacked on top of each other. These photos of a chimpanzee, an orangutan, clearly the talus is lying next to the calcaneus, not on top of it. And the posterior facet of the subtalar joint is oriented vertically, not horizontally or parallel to the ground. So when we compare the human skeletal alignment compared to primates, the lamina pedis is entirely a flat plate with primate foot. Subtalar joint is oriented vertically, not horizontally. In the humans, we take this foot plate and it's twisted where the calcaneus becomes positioned beneath the talus. This change actually occurs in utero. Lewis went on to show a picture of the subtalar joint of a non-human primate foot. This is a chimpanzee foot. The posterior facet is oriented vertically. And then the critical change in the human foot is the stacking of the talus on top of the calcaneus, and the posterior facet is now oriented horizontally, and this allows the axis of the subtalar joint to be inclined to provide supination and pronation. All of these changes occur in utero. This was documented early by Serafian and later by McCarthy. And this is a picture of a 1-week embryo, human embryo, where the bones of the feet are hardly developed and they lie in a flat plane. Critical change occurs here in week 8. Talus and calcaneus lie flat. The forefoot, all of the forefoot bones are flat in a single plate with the rear foot bones. The calcaneus abuts on the fibula. In 2 weeks' time, a rotation occurs where the calcaneus has rotated beneath the talus and the foot plate has now twisted. This all occurs within the first 9 months after gestation. After that, a rotation of the foot occurs to move the foot out of supination. The talus moves from a very adducted position at 5 months to a much straighter position in the transverse plane. And a valgus rotation occurs in the 5-month-old fetus. This is after birth, through 7 months and adulthood, where the talus rotates in a valgus rotation movement to pronate the forefoot on the rear foot. The metatarsals follow. By the adult period, which is after age 14, the valgus rotation of both the talus and the metatarsals has pronated the forefoot from a very supinated position to hopefully a rectus position relative to the heel. One differentiating feature of humans to other primates is the so-called mid-tarsal break. There is a period of accentuated movement of all other primates in the sagittal plane during mid-stance and propulsion, a so-called break across the midfoot joints that does not occur. The human foot remains relatively rigid so that the tendo-Achilles lifts the heel and the entire foot across the metatarsal heads. Some human feet actually do show a mid-tarsal break, and certainly the adult acquired flat foot does. But the healthy human foot compared to the non-human primate, no mid-tarsal break. The unhealthy posterior tibial tendon dysfunction has an obvious mid-tarsal break, which we will see in gait analysis and during single foot heel rise. So what prevents the mid-tarsal break in the human foot? Is it really the entire mid-tarsal joint? It actually isn't. It's the calcaneocuboid joint. It's that joint that prevents the midfoot from moving excessively in the sagittal plane during mid-stance. And the anatomist who really pioneered the insight into this was Finn Bogen-Moller. A series of epic papers published in the late 70s, early 80s. It was Bogen-Moller who identified the unique features of the calcaneocuboid joint, starting with the ligaments, the long plantar ligament, which is a key stabilizer of the lateral column, as well as the bifurcated ligament and the short plantar ligament. He also identified the key osseous alignment of the calcaneocuboid joint and the structures that enabled the cuboid to be elevated from the ground during mid-stance and propulsion, as compared to all other non-human primates. So the stability of the human calcaneocuboid joint is partly built upon a plantar medial bone projection on the calcaneal facet of the cuboid, identified by both Bogen-Moller and by Lewis. This is a osseous locking due to a prominence of the cuboid in the human foot not seen in the non-human primate foot. The shape of the human calcaneocuboid joint is a saddle-shaped joint which has the ability to undergo a locking mechanism within itself, as Bogen-Moller described. He says the calcaneocuboid joint becomes closely packed by pronation of the forefoot in relation to the hindfoot because of a congruency between the joint surfaces obtained in this position as the calcaneus overhangs the cuboid dorsally and stops the movement. He was really the first person to describe this osseous locking of the calcaneocuboid joint brought on by pronation of the forefoot on the rear foot, twisting of the forefoot on the rear foot exactly as McConnell described 20 years earlier. In summary, Bogen-Moller felt that the locking of the lateral column at the calcaneocuboid joint stabilized the entire midfoot, allowing for weight transfer to the medial column of the foot to allow rigid lever propulsion and engagement of the windlass mechanism. He observed in gait analysis of non-human primates compared to humans that healthy human feet push off across the first metatarsal and the hallux, but only if the lateral column has been stabilized during mid-stance. He described the transverse axis push-off at the first and second MTPJ as being healthy, and the oblique axis push-off across the lateral forefoot as being unhealthy. If everything works well during mid-stance, the peroneus longus pronates the forefoot on the rear foot, locks the calcaneocuboid joint, and allows the foot to push off across the transverse axis. So this is when everything works well according to Bojan-Moeller, and this is when it doesn't. So the twisted plate model, as it evolved through Bojan-Moeller, was identifying these key anatomic features, such as the calcaneocuboid joint locking mechanism, the elevation of the lateral column of the foot to enhance the lever arm of the peroneus longus to pronate the forefoot on the rear foot, and then later the tensioning of the ligaments to provide elastic recoil and energy return for push-off. This was all described really before 1980. Now, the person who, in my mind, really described the twisting plate mechanism in the most simplistic and most useful clinical form was Serafian, and he described it in all of his editions of his anatomy textbooks, but also described it in several peer-reviewed publications, most notably Foot and Ankle International in 1987. Palikian's books, and particularly starting with the third edition, are probably the best biomechanics texts of the foot that I have ever read. And I love his incorporation of the twisted plate into a very large segment of this book in the opening chapters. And he concisely described this in another article in Foot and Ankle called Functional Characteristics of the Foot and Plantar Aponeurosis under Tibio-Talar Loading. He was interested in describing how we tension and relieve tension of the plantar fascia during mid-stance and push-off. And he started with a description of the twisted plate of the human foot, where the unique feature of the talus oriented vertically over the calcaneus compared to the metatarsals, which are oriented horizontally, creates a twist of the foot plate bones and creates both a medial and lateral arch. He then described how twisting this foot plate can cause tension or relieve tension in the plantar fascia. He showed that if we twist the rear foot towards the midline or invert the rear foot, we actually raise the arch of the foot. And that's something that's well known to most clinicians. But he also showed that twisting the forefoot in the opposite direction, in eversion, accomplishes the same result. Twisting the rear foot into inversion is coupled with forefoot eversion, and in either case, it raises the arch of the foot. He demonstrated this with a simple plate of plastic, and he took the plate and oriented it like the human foot, the rear foot vertical and the right-hand side, forefoot horizontal, and he twisted it where he inverted the rear part of the plate on the right-hand side. This induces a change or an arch shape to the medial side of the plate and the lateral, but it also shortens the length of the plate from 21.5 centimeters to 20.5. If he turned the rear part of the plate into valgus, he untwisted the plate and the plate lengthened. So here was the simple demonstration of the behavior of the foot plate. He showed how the foot plate can be twisted in the forefoot by twisting the forefoot into inversion with what would look like a medial forefoot post. It untwisted the foot plate. When he put a valgus or lateral forefoot post, it twisted the foot plate and raised the arch. He drew a diagrammatic representation of how pronation of the forefoot is coupled with supination of the rear foot and external rotation of the talus and presumably the tibia above. He then showed how supination of the forefoot is coupled with pronation of the rear foot, and in this drawing, increases strain in the plantar fascia. He went on and showed an anatomic demonstration with a cadaver where he took a cadaver and applied axial load, and he twisted the foot plate by internally rotating the tibia. And this actually untwists the foot plate. Internal rotation of the tibia everts the heel, inverts the forefoot, and he showed how it increased tension in the PA, which is the plantar aponeurosis. He took that same cadaver and externally rotated the tibia. This inverted the rear foot and pronated the forefoot, and he showed how the plantar fascia became, as he says, relaxed and undulant. So if we look at these rotations brought on by the tibia, internal rotation of the tibia untwists the foot plate. The untwisting is eversion of the heel or rear foot, inversion or supination of the forefoot. Reciprocally, if we externally rotate the tibia and fibula and the talus, the rear foot inverts and the forefoot pronates. This is clearly not a one-dimensional deformity. Besides just a medial and lateral arch, the twisting of the foot plate also induces a change in the transverse arch. There's new attention being paid to this arrangement of the tarsal bones through the midfoot, and this transverse arch is thought by some and by an engineering principles to be more important in stiffening the foot than either the medial or lateral longitudinal arch. Engineers have studied how twisting of non non-biologic plates, just whether it be of metal, carbon fiber, etc., develops compressive forces in the center of the plate, which provides longitudinal stability. Cables, for example, represent twisting of long strands of metal material to impart stiffness and strength. There's lots of engineering studies on the mechanism of twisted plates in non-biologic tissue, whereby we learn that as we twist these plates, we develop more compression in the middle of the plate, which in the foot, in the middle of the arch of the foot, provides stability. When we watch people walk and we do gait studies, we know that as the foot untwists after heel contact, it begins to twist into propulsion. There's both a loosening and an increase of compression through the bones of the arch, the medial, lateral, and transverse arches. During the loading phase, the foot plate untwists as the rear foot pronates and the forefoot supinates. There's also sagittal plane dorsiflexion of the forefoot. This causes the soft tissues, the plantar ligaments, to elongate and store elastic energy. The deformation, increased tension at these tissues will later decelerate foot pronation and certainly aid in propulsion or push off of the foot as energy is stored and then released during the final phase of gait. So this twisting mechanism of the human foot plate and the strain on ligaments, the storage of energy and release of energy is really integral to how the foot functions mechanically for walking and running. The pronation of the forefoot coupled with supination of the rear foot really wasn't first described by McConnell. It was actually described by a famous orthopedic surgeon way back in 1929, published in the Journal of Bone and Joint Surgery. And Steinler described how the forefoot supinates in compensation for pronation of the rear foot in the pes valgus foot deformity. And he drew these drawings of how the pronation of the rear foot causes supination of the forefoot. If we put this together with the twisting of the plate, we realize that as we raise the medial longitudinal arch and plantar flex the first ray with forefoot pronation, we not only decrease strain in the plantar aponeurosis, as Serafian showed, but we theoretically improve range of motion of the first metatarsophalangeal joint during push-off of the transverse axis. So this is the mechanism that we would like to see during the push-off phase of gait. Early on, many researchers, including Root, showed the triplane motion of the foot during the various stages of the walking gait cycle. And clearly, we know from kinematic studies that the foot untwists and then twists at key stages during the stance phase of gait. And this all has an energy storage and energy release function. If we look at this twisting of the foot, this is a cadaver that I took, and I'm twisting the tibia and fibula into external rotation here and internal rotation. We can see the bones of the foot moving in response, and it's clearly not in one plane. It's clearly a twisting of the forefoot on the rear foot. It's a three-dimensional complex movement that we really still don't fully understand. So let's take this now and put it in a more usable clinical application and see how this might apply to what we do when we treat foot disorders. The twisted plate model of the human foot has actually been discussed and described by many eminent surgeons going back really to McConnell's time and up until just very recently. One paper that caught my eye was this paper by two French pediatric orthopedic surgeons who looked at the twisting of the talonavicular and subtalar joints. And instead of using the term lamina pedis, they coined the term calcaneal pedal unit, which is the identical set of bones, the foot plate that was described by McConnell. Sering and Weikart pointed out that the calcaneal pedal unit and the movement of the bones of the foot plate were described really going back to 1867 with Duchenne. And then they cite McConnell. They also cited Hicks. I would also throw Jim Ganley in there, as I'm about to show you. He described a twisting plate mechanism. And then up until today, as I'm about to show you. One thing that Sering did that others didn't do is they described the segmentation of the foot in a new way. They called it a horizontal segmentation, separating the calcaneal pedal unit from what they called the talotibiofibular unit. This is compared to the more common way we see people segment the foot, either in rear foot or forefoot, or medial column versus lateral column. This is the twisted plate segmentation, where the talus is considered part of the leg bones and the lamina pedis rotate beneath the talus independently. Much different than the segmentation we commonly look at with medial and lateral column or rear foot versus forefoot. And so, again, Sering and Weikart described the forefoot pronating as the calcaneus inverts, and they described how forefoot supination is coupled with calcaneal eversion. They drew pictures showing internal rotation of the tibia coupled with rear foot pronation and forefoot supination. They also showed a demonstration, which many of you may use in your clinical setting, where any human asked to internally rotate their leg will immediately pronate their rear foot. And what many people don't notice is that it automatically supinates the forefoot. But Sering and Weikart pointed out that foot deformities are really failures or over-exaggeration of the twisted plate mechanism, whether it's a cavus foot with an overly pronated forefoot or a pes planus foot with an overly supinated forefoot. Surgical procedures that block forefoot supination will block rear foot pronation. This is a concept which is hard for many people to grasp, but from a surgical standpoint, it's been proven over and over that if you can block supination of the forefoot, you will block pronation of the rear foot. And I'll show you how you do that with a surgical procedure. Reciprocally, if you can block pronation of the forefoot, you can block inversion of the rear foot. That would be a cavus deformity. So conditions which plantar flex the first ray will supinate the rear foot. And that's why surgical procedures that dorsiflex the first ray will take the rear foot out of supination. Reciprocally, conditions which dorsiflex the first ray will pronate the rear foot. Foot orthoses that block forefoot supination will block rear foot pronation. This is kind of a new concept. We always look at foot orthoses to work in the rear foot only, with rear foot posting, deep heel cup, etc. And they are effective in blocking pronation. But we can also block pronation by preventing forefoot supination. I'll show you this in several ways in the rest of this webinar. So to prevent forefoot supination and correct rear foot pronation, we might want to plantar flex the medial column. And that's really what a cotton osteotomy does. It literally pronates the forefoot. It plantar flexes the first ray, but it also indirectly prevents forefoot supination. A foot orthosis, by preventing the lateral column of the foot from dropping to the ground during forefoot supination, will prevent rear foot pronation. The orthosis must be fairly rigid and prevent deforming too much under loading, and hence will prevent forefoot supination during mid-stance period of gait. A semi-rigid to rigid orthosis that intimately contours to the calcaneocuboid joint will prevent forefoot supination. Just 2 years ago, a group of eminent pediatric orthopedic surgeons teamed together to again focus on this concept of the calcaneopedal unit, or the twisted plate concept, in surgical approaches to clubfoot, cavus foot, and pes planus. They again segmented the foot, considering the talus to be part of the leg, and this set of bones known as the calcaneopedal unit. They also talked about the reciprocal coupling of the forefoot to the rear foot. They also talked about the importance of the midfoot joints and the tarsal arch mechanism across the midfoot, and the importance of that in providing stability to the foot. They showed the results of surgical procedures for a cavus deformity where the medial column of the foot is dorsiflexed to supinate the forefoot and take the foot out of extreme inversion or supination deformity. Supinate the forefoot will allow the rear foot to pronate. They then took a pes planus foot and performed an Evans procedure, a lateral column lengthening to correct flat foot deformity. This procedure does not directly use a twisted plate mechanism. It stiffens the lateral column of the foot so that the calcaneocuboid joint is more stable, and then it allows the peroneus longus to pronate the forefoot on the rear foot, and thus indirectly pronating the forefoot on the rear foot to correct flat foot. So you'll notice that a lot of surgeons now are considering the talus to be part of the leg, not the foot. The talus has no ligamentous and no muscular attachments. It passively moves, particularly in the transverse plane, with the tibia and the fibula. In the adult-acquired flat foot, internal rotation of the tibia drives the talus medially, and the lamina pedis beneath it rotates laterally. This extreme abduction of the entire foot beneath the talus is one of the hallmark signs of the adult-acquired flat foot. Radiographically, we see this with uncoverage of the head of the talus, and it is the hallmark of the adult-acquired flat foot deformity. How do you correct that joint, particularly non-surgically, with bracing? The answer is you have to control the tibia. By controlling internal rotation of the tibia, you control internal rotation of the talus. So we can move on either side of the complex to accomplish this kind of correction. In this case, controlling transverse plane of the tibiofibular unit as reciprocal correction of the foot plate of bones. Jim Ganley, really a legend in our profession, who died much too soon at age 52, was really one who first described how flat foot deformity in infants was really a rotation of the lamina pedis beneath the talus. How the talus was held in the ankle mortise and the tib and the foot plate moved beneath it. He really was a real twisted plate guy in the sense that he showed the Ganley night split, moving the rear foot into inversion and the forefoot to eversion in order to correct a congenital calcaneovalgus flat foot deformity. We find that in the correction of flat foot surgically, the most effective procedures stiffen the lateral column, whether it's lengthening the lateral column or wedging. And the lateral column lengthening procedure has a profound effect on a flat foot deformity for reasons we don't really fully appreciate, but if you understand the twisted plate mechanism, it makes perfect sense how it accomplishes such a profound correction. A simple 1 centimeter graft placed just proximal to the calcaneocuboid joint imparts profound three-dimensional correction of the flat foot deformity, primarily by, this is pre-op and post-op, look at the elevation of the cuboid off the ground with this procedure, and elevation of the lateral column, because it stiffens the entire lateral column so that the ligaments and the muscles affect more efficiently across the midfoot. Lateral column lengthening does increase lateral pressure, and it can over-stiffen the lateral column, and some of the complications of an Evans procedure are lateral column pain and even stress fractures. But this is really the mechanism that it works. It enhances the Finn-Boschen-Moeller's observation of what's necessary to stabilize the foot for medial transfer of load and propulsion. We can accomplish the same thing with medial rear foot wedging following the twisted plate principle. The medializing calcaneal osteotomy does just that. It twists the rear foot into inversion, moves it medially, which we know will then cause or enhance pronation of the forefoot on the rear foot. So the medial displacement of the calcaneus is a powerful procedure for flexible flat foot deformity. And numerous studies have been carried out to show that it decreases ligamentous strain, particularly that in the spring ligament. So it really indicates that it's twisting the foot plate in a favorable way, because pronating the forefoot on the rear foot decreases load on the spring ligament. Now, Serafian showed this visual presentation of how you can decrease strain on the plantar aponeurosis by twisting the foot plate. So a study was done by Kogler almost 20 years ago that actually verified Serafian's own observations. Kogler basically took 9 fresh frozen cadaver specimens and mounted them on a frame, and he placed wedges under the foot, either medial or lateral, forefoot or rear foot. And then he put a strain gauge in the plantar fascia to determine how the wedges would either load or offload the plantar fascia. This is his apparatus. I think most people would assume that a varus wedge, under the forefoot in particular, would most likely decrease strain in the plantar fascia, and a valgus wedge would pronate the foot and increase strain in the plantar fascia. But in fact, Kogler found just the opposite. In every case when a forefoot medial wedge was placed under the cadaver, it increased strain in the plantar fascia. When he applied a lateral forefoot wedge, it decreased strain in the plantar fascia in each and every case. These are the statistics. Interestingly, rear foot wedges had no significant effect in this particular study. It was only wedging the forefoot that decreased strain in the plantar fascia. This wedge actually increased strain. This wedge decreased strain. But if you understand the twisted plate mechanism, that makes perfect sense. I took a patient of mine to see if wedging of the foot would actually impart those same changes. And I put the patient's foot in a neutral position at the rear foot, and indeed this foot would be considered a very healthy or normal foot in terms of forefoot to rear foot relationship. No significant varus or valgus. I then placed a 6 millimeter, which is a very thick wedge, admittedly, either lateral or medial under the forefoot, and I took x-rays of the foot to see how the skeletal alignment would change. Without any wedge, most people would agree this is a very healthy, normal foot. I was interested in measuring how the length of the foot relative to the arch height would change with these wedges. So with a medial wedge placed under the forefoot, a varus wedge under the forefoot, we see the wedge dorsiflexes and elevates the first ray significantly. And I measured a 20-degree calcaneal inclination angle and a length of the arch of 20.5 centimeters. I then put the same wedge laterally under the same foot and took an x-ray. In this case, the first ray planar flexed and the calcaneus inclination angle increased. In comparison, with a lateral wedge, we have a calcaneal inclination angle of 25 degrees. With the medial wedge, it's lower, it's 20 degrees. But the length of the arch actually decreased by almost half a centimeter, comparing lateral to medial. And length of the arch would translate into tensile loading of the plantar fascia. So how could we apply this knowledge to enhance orthotic treatment outcomes? I want to make something really clear. Regardless of rear foot and to forefoot deformity, pronation of the forefoot on the rear foot is required to stiffen the lateral column in every foot, regardless of whether they have a forefoot varus or forefoot valgus. So all feet, by the research I've shown you, benefit from stiffening the lateral column, which is accomplished by pronating the forefoot on the rear foot. A stiffer lateral column will enhance load transfer through the first ray and push off across the transverse axis. Therefore, we need to start with impression casting or scanning of the foot when the forefoot is fully pronated on the rear foot. We must capture that shape in the orthotic foot plate or the foot plate of the Ritchie brace to gain that benefit of a locked and stable lateral column and calcaneocuboid joint. Positioning of the forefoot to rear foot is then carried out, and posting the forefoot to rear foot deformities are carried out by the lab based on that impression cast. If there's a forefoot varus deformity evident, we post them in a forefoot varus. If it's a valgus, we post it in valgus. It's how we cast the foot in the first place. Mert Root, back in 1982, by the way, called upon us to embrace biomechanics into our practices. And if we don't, other medical specialties will definitely take it over. And that is definitely what's happening today. He then went on and described how an orthosis works. And he says it's designed, a foot orthosis is designed to resist specific abnormal forces that we identify via examination of the foot and then design an orthosis to improve function of the foot. The functional foot orthosis is not an arch support. It does not, quote, balance a foot. It does not hold the foot in a particular position. It does not accommodate lesions or painful areas by itself. It will with extensions and other enhancements. Most importantly, as he says, a functional foot orthosis only resists abnormal forces and promotes improved foot function. So the key is the function of a foot orthosis is not to support the medial arch of the foot. It's the position in which the foot is casted for the functional orthosis to work. And according to Root, the position must be with the foot, the mid-tarsal joint, fully pronated. When we do this, the orthosis should not be expected to have any excessive pressure on the medial arch throughout the stance phase of gait. Now, Root emphasized casting the foot off weight bearing and pronating the forefoot on the rear foot, which twists the foot in a favorable direction. And why did he recommend casting the foot off weight bearing? Because he knew, and many others know, that the human foot immediately, when it touches the ground, untwists with weight bearing. That's a normal mechanism. It is supposed to untwist during the contact phase of gait. So we cast the foot off weight bearing so we can enhance the optimal position of the forefoot maximally pronated on the rear foot for stability. I did this study with Jeff Root, Mert Root's son, published it in uh, Podiatry Management magazine about 15 years ago. And we just took a single patient, and Jeff casted this woman off weight bearing using the Root technique. And then he took the same patient and casted her semi weight bearing sitting in a chair with her foot resting on foam, and then fully weight bearing standing up with her foot on the foam on the ground. He compared the three negative casts. The Root technique suspension non-weight bearing cast captures a forefoot valgus deformity, and in this case, a pronated forefoot on the rear foot. The minute that patient put their foot on the ground, the foot untwisted, and now a forefoot varus is captured in the cast. When they bear full weight on the foot, interestingly, the twisting is less than when it's a partial weight bearing. But in either way, when the foot was placed on the ground, it untwisted, and we lost that stability pronation of the forefoot on the rear foot. So when the lab gets these casts and balances them, they're going to balance these two casts inverted at the forefoot or supinated at the forefoot, and this foot will be captured as it truly has a forefoot valgus deformity. The problem is this patient truly has a forefoot valgus, but because of an error in casting, they're going to be positioned with their corrective orthotic with a forefoot varus post, which will supinate the forefoot on the rear foot and encourage rear foot pronation. Orthotics can be enhanced for the twisted plate. Again, we recommend balancing the forefoot to the rear foot according to your examination. And if they have a forefoot varus, you put a forefoot varus post on, but you cast them using the twisted plate mechanism. And if you're not getting the results from that fully corrected orthotic, you can further twist the forefoot on the rear foot by applying material on the top surface of the orthotic foot plate. That's exactly what a reverse Morton's extension does. It twists the forefoot on the rear foot or everts the forefoot further on the rear foot in cases where further control is needed. A forefoot valgus post does not twist the foot plate. A forefoot valgus post twists the entire orthotic device from the supportive surface, and it tilts it into pronation or valgus in the frontal plane. It doesn't twist only the forefoot on the rear foot. So don't assume that a valgus forefoot post follows the twisted plate mechanism. It does not in any way. Only when you cast the patient with a forefoot everted on the rear foot or place material on the top surface of an already finished orthotic or insole will you actually further twist the forefoot on the rear foot into pronation. So regardless of whether we capture a forefoot varus or forefoot valgus, the lab should balance the cast either intrinsically or apply extrinsic posting. And we try to bring the rear foot to perpendicular. And in so doing, if the forefoot is locked on the rear foot, this position will be maintained during the push-off phase of gait. We can add further twisted plate enhancements such as a medial skive, which really is nothing more than adding a varus wedge effect to the inside of the orthotic heel cup. It doesn't tilt the entire orthosis. It twists the plate by applying an inversion moment to the calcaneus. So by inverting the heel only of the orthosis on the forefoot, we twist the foot plate in a favorable direction. We will see the foot untwist significantly when the posterior tibial tendon and spring ligament rupture in the adult acquired flat foot deformity. In this case, there is not a fixed forefoot varus deformity. There's an acquired forefoot supinatus because positionally the forefoot has over-supinated. If we correct the rear foot, we see a supinated forefoot to rear foot, but if we push down on the first ray, it's completely reducible. If this was a true forefoot varus, the first ray would not come down. The forefoot varus is a fixed deformity. This acquired reducible deformity is called forefoot supinatus. It can be easily visualized in patients with stage 2 or stage 3, as this patient's left foot, bringing the rear foot into a subtalar neutral position. We look at the forefoot to rear foot and we see there's at least 20 degrees of forefoot varus relative to the rear foot. But if we push down on the first ray, that forefoot varus completely reduces to a forefoot valgus now, because this is a supple, reducible, acquired deformity that wasn't there when this patient was 15 years old. We must reduce forefoot supination deformity following the twisted plate theory when we cast patients with adult acquired flat foot. And the only way we can reduce this is if we push down on the first ray. We must reduce all that acquired forefoot inversion deformity. If we don't, we will capture a forefoot varus and the lab will balance that varus and hold the forefoot supinated. If you hold the forefoot supinated, the rear foot will be held pronated. If you pronate the forefoot on the rear foot moves out of a pronated position to a neutral or even supinated position. We must correct forefoot supinatus when we cast for a Ritchie brace, particularly when there's adult acquired flat foot. It follows the twisted plate theory perfectly, but more importantly, it gives a much better outcome with Ritchie brace therapy. I describe this in quite a bit of detail in various videos that are all on the Ritchie brace website. We have an education section on the website, and we have a whole section on casting with videos, and some of them are devoted to forefoot supinatus reduction. Many feet, simply by pronating the forefoot on the rear foot and moving the rear foot into subtalar neutral, we can get an excellent scan or cast of the foot, and we don't have any concern about forefoot supination deformity. But a big problem in digital casting is the assumption that you can just scan the foot hanging in space. And most feet, when they're hanging in space, have an untwisted foot plate. The forefoot is markedly inverted on the rear foot. It is supinated. And when this foot is casted in this position, the orthotic will hold it in that position. And if you hold the forefoot supinated, the rear foot will pronate. So we must follow the same criteria when we scan a foot as we do when we cast a foot. The practitioner must position the foot into subtalar neutral and maximally pronate the forefoot on the rear foot in order for us to get a stable shape of the foot plate and get optimal functioning of the foot on the foot plate with either the Ritchie brace or the foot orthotic. So just in closing, the adult acquired flat foot deformity is a classic demonstration of an untwisted foot plate. It has an everted rear foot and an inverted or supinated forefoot. We have to correct that, as well as the transverse plane abduction of not only the navicular but the entire forefoot on the rear foot. This is coupled with internal rotation of the tibia and the talus. The Ritchie brace can address all four of those factors, both above and below the lamina pedis. We want to invert the rear foot. We want to pronate the forefoot. We want to bring the forefoot out of abduction, and we want to externally rotate the tibia and talus. This is what we want to accomplish. We do it by casting the way I showed you, restrain internal rotation of the tibia, control medial displacement of the talus, and abduction of the forefoot. We want to go from here to here with the Ritchie brace, both above and below the ankle joint complex. And it starts with positioning the foot properly during the casting or scanning process. We can take a foot like this and take it to here, or this on the left to here. It all follows the twisted plate principle, not only with the casting, but with the actual fabrication and enhancements of the brace with a medial skive for the rear foot, a lateral phalange for the forefoot, and maximally pronating or plantar flexing the first ray during the casting procedure. So just to go over some key points that I've tried to make here about the application of twisted plate. We're not in any way advocating that all feet need rear foot varus posting and forefoot valgus posting. The posting should be done according to each individual foot deformity. Regardless of that deformity, though, all feet should be casted with maximal forefoot twisting on the rear foot, i.e. pronation of the forefoot on the rear foot. Keep in mind that a fully pronated forefoot on the rear foot will maximize resistance to rear foot pronation. A forefoot varus can be supported with forefoot varus posting while still enhancing twisting the forefoot on the rear foot with the shape of the orthotic foot plate and the impression casting. Hopefully that's piqued your interest in kind of a new way to look at foot mechanics, and certainly justifying why and how we cast for fully functional foot orthoses and the Ritchie brace. This webinar is brought to you by 15 of my distributors who over the past 25 years have made the Ritchie brace a reliable and predictable treatment tool for a myriad of different foot pathologies. All of these labs are featured on our Ritchie brace website. You can visit each of their individual websites by clicking on their logo and learn more about not only their foot orthotic line, but what they can do to enhance providing the Ritchie brace. So with that, I'm going to open it up to Sarah.
All right. Yay. I'm excited to be back.
And
I love it. You did exactly 1 hour. We were at 9 o'clock. So that pairs well with my OCD. So
okay.
We have a couple of questions that have come through. So I do encourage everybody who is online, and it looks like everybody stayed online from the beginning. So I'm excited that everyone is still with us. If you have questions, this is the time to put those into your question box, but let's get to it. The first one we have, Dr. Ritchie, can forefoot valgus posting using 3D orthotics, I'm sorry, I'm going to start over. Can forefoot valgus posting using 3D orthotics / correction help induce twisted plate as compared to traditional lab balancing methods?
Yes, it could. You would have to be, there would be some guesswork involved, but you could, with 3D CAD CAM design, evert further the forefoot on the rear foot in the shape of that foot plate beyond what was captured in the negative cast. And it would change the shape of the foot plate, which is different than just applying a forefoot valgus post. Keep in mind, a forefoot valgus post doesn't necessarily change the shape of the foot plate. It just tilts the entire foot plate.
I do have another question, but Dr. Ritchie, do you want to put on the cover, the title slide, so that your contact information is up for everybody? Just while we're doing the Q&A, I figure that might help. Awesome. Yep. All right. Can you please discuss fitting the Ritchie brace into a shoe? And that's on the website, so you can check that out too.
Well, I mean, I always say a Ritchie brace fits into a shoe pretty much as well as a functional foot orthosis in most cases. I mean, it does have a 35 millimeter heel cup, but a 35 millimeter heel cup is no wider than an 18 millimeter heel cup. So unlike a gauntlet brace, the Ritchie brace does not go around the back of the ankle and push the foot forward in the shoe. It doesn't displace the foot anteriorly at all, any more than a foot orthotic. So it does take up some room compared to the non-brace, but not really any more than any fully corrected functional foot orthosis.
And I let the physician know that I will send the PDF to the shoe fitting guide.
Okay.
All right. How do you cast a severely pronated foot to correct or compensate for the deformity, i.e. get the foot into a more neutral position?
Well, I think I showed that in that one video. You have got to fully pronate that forefoot on the rear foot. It really means pushing down on the first ray while the rear foot is still maintained in a neutral position. So you're using retrograde force against the rear foot to keep that subtalar joint neutral but you are putting full pronatory force across the forefoot to reduce all forefoot supination. Now, some of these stage 3 and certainly stage 4 adult acquired flat feet, you cannot move the subtalar joint out of a fully pronated position because it's a rigid, non-reducible deformity. I would invert that rear foot as much as it'll go, but it won't probably get to neutral or get to a perpendicular attitude to the leg. But I would still twist that rear foot into maximal inversion, and I would twist the forefoot into maximal eversion.
And the video, Dr. Ritchie, is that the removing supinatus video that we have?
Yes, exactly.
Okay, because I said I'll send the link over to that as well. Those are all the questions we have. Everyone's quiet tonight.
Okay, I'm not sure what that means, but
I think it means, I mean, you did such an amazing job that how could there be any questions? Oh, exactly. I lied. One more came in, and then we're going to wrap it up as we are past the time here. I find that using the windlass mechanism to aid in plantar flexing, the first met. You?
Yeah, that's a good point. You know, my good friend, the late Paul Scheer, taught that. He too agreed that we must maximally pronate the forefoot on the rear foot when casting for foot orthoses. And to enhance that, he suggested you dorsiflex the hallux. Because when you do dorsiflex the hallux, it does reciprocally plantar flex the first ray. My only criticism of that is it does bowstring the plantar fascia. And by bowstringing it, it pushes the plaster or fiberglass away from that critical part of the foot. So you're not going to get that orthosis contour there as tightly as you would if that plantar fascia was not bowstrung. So, and I've talked to Paul about this many times, that I can still get that first met to come down without dorsiflexing the hallux and without bowstringing the plantar fascia. And I'd rather not distort it with the bowstringing. So that would be my only caution. But I think the idea is very, very good and very proper either way.
Awesome. All right. Well, that is going to wrap it up for us this evening for the first 2024 Practice Partner Academy with Dr. Ritchie. Thank you so much. Obviously, like I said, everyone stayed online. So I think today was a great success. And I appreciate your time as always. Safe travels. I know you're on the other side of the country than you're normally used to. So be safe getting back to the West Coast. And everybody who's online, stay safe, stay warm. Hopefully I'll see you in Florida. I just looked at the weather. I am excited to get out of Illinois. And I will see you next time. Keep your eyes peeled for emails from podiatrymeetings.com as we have a whole schedule of Practice Partner Academy sessions for you in store. So we'll see you soon. Bye, guys.
Take care.